a very important subtopic of the diabetes, diabesity. So both the diabetes and obesity is the diabesity, because for the simple reason that world capital of obesity is India. So it's that India has a dubious distinction of having on one hand more and more over eating and obesity, on the other hand malnutrition and underweight. So we are very much interested in the obesity because the diabetes is a very commonly associated in the obese individuals or the overweight individuals. So it's a major epidemic of the 21st century. 30% of the most Western population are obese, contributes to more than the 4,000 deaths annually in the US itself. They lead a fall in the life expectancy, childhood obesity emerging as a major problem. So these are all very common, even in you can apply to our Indian population also, because it's a big problem nowadays. Here most of our children are also obese. So there is a fall in the life expectancy if the obesity continues for the longer periods. So that boy is not happy with the single ice cream. Okay, 2 ice creams. Obesity affects up to a third of the adult Asian Indians. So you can imagine 140 crores of the Indian population and up to 1/3, 33% of the obese means very high numbers. Numbers are rapidly increasing in association with the rising urbanization. So because of the urbanization, because of the localization, okay, so these are people. Even children are not exempt. Now the childhood obesity is a very common problem. So earlier, no, the common type of the insulin diabetes in the children is the type 1 diabetes. Now it is a type 2 diabetes even in the children because of this only. Because of the childhood obesity, so we are seeing a lot of the people even at the age of 8 years, 10 years, 12 years, obesity, diabetes. Diabetes with acanthosis nigricans in the children. Children diabetes, acanthosis nigricans, skin tags, etc. So a lot of insulin resistance in the children because of the childhood obesity. So partly because of Narayan and Sri Chaitanya. So no playgrounds. So schools from morning 7 a.m. or 8 a.m. to till 7 p.m. or 9 p.m. and tuitions, home tuitions. How do we define the obesity? So you all know that BMI. So that is the BMI is weight in kgs divided by height in meters, square meters. Based on the BMI, individuals can be classified as the underweight or the normal weight, overweight or obese. So this is the WHO category. So underweight means less than 18.5. Normal weight 18.5 to 24.9. This is for the Westerns. Whereas for the Indians, it is 22.9. So that means 23. Up to 23 is our normal BMI. And 25 to 29.9, that is a 25 to 30 is the overweight for the Western population. For us, it is 23 to 25. Some book says 23 to 27. Okay. So then class 1 obesity. So starts from the 30 outside the India. In India, obesity starts at 27 BMI. Okay. So am I clear? So for us, the normal BMI is less than 23. So for us, overweight means 23 to 25 or 23 to 27. So if you consider 25 as the upper normal for your overweight, then the obesity starts at 25 BMI or 27 BMI. So this classification may not be valid for the Asian Indians. Already I told you our Asian definitions. So this is the very important. Thin fat or metabolically obese India. Indians develop most of the metabolic correlates of the obesity despite being non-obese by global standards. He appears he appears normal weight, but if you see the fat, a metabolically active fat, because of the abdominal adiposity, because of your adiposity in the upper abdomen. So that is viscerally very active with a lot of the adipocytokines. So the two very different types of the obesities here, the apple versus the pear. So which one is safe, which one is bad? The apple shape is bad because obesity in the upper abdomen is very bad, more and more adipocytokines. So the lower abdomen obesity is good, upper abdominal obesity is very bad. And both the upper and lower abdominal is very bad. So this apple shape indicates the increased visceral adiposity, which is an important risk factor for the cardiovascular disease. So BMI does not differentiate between these two types of the obesity. So for that reason, don't be happy with the BMI alone. Okay. So you need a waist circumference also. So this waist circumference has been shown to be a good surrogate marker of the abdominal adiposity. In India, values more than 90 centimeters in the males, more than 80 centimeters in the females are considered abnormal. So more than 36 inches in the males and more than the 34 inches in the females is dangerous. So that is the waist circumference. It's a major etiological factor in the type 2 diabetes because type 2 diabetes is very common in overweight and obese individuals, may influence response to the therapy. Because if you reduce the obesity, sometimes there will be the reversal of the diabetes also possible. If you lose the 10% of the total weight or 15 to 20% of the total weight, so definitely the reversal of the diabetes is also possible. So strong bearing on the diabetes complications. So the more the obesity, so the more the risk of CKD, more the risk of ischemic heart disease, more the risk of peripheral vascular disease. So definitely the diabetic complications will be very high in the obese diabetic individuals. Weight gain due to the anti-diabetic agents, that is also there. So some of the people, they are obese, they are getting the sulfonylureas. So sulfonylureas will cause more and more weight gain. And they are obese and they are getting the pioglitazone. Again, the pioglitazone will increase the body weight. So as a diabetologist of tomorrow, you should know which agents, which diabetic agents, which drugs will increase the body weight, which drugs will reduce the body weight, which drugs will be the neutral as far as the weight is concerned. That is very, very important. So you should advise the weight lowering OHS in obese individuals, weight gaining OHS in underweight diabetic individuals. Okay, in a normal weight diabetic individuals, weight neutral diabetic agents. This is a very important. See, visceral fat is a very, very dangerous. So how it is very dangerous? Because it causes increased free fatty acids, inflammatory mediators, and adipocytokines. Okay, when the visceral fat is more, so how it happens to be the FFA by lipolysis. So more the lipolysis, so releases the more the free fatty acids. So these free fatty acids will cause you ketone bodies, acetone, acetate, beta hydroxybutyric acid. So that's how it develops diabetic ketoacidosis. And then the adipocytokines. A different adipocytokines will be released from the visceral fat. One is more healthy and more good is the adiponectin. But unfortunately, Indians, adiponectin levels are at a lower level when compared to your HDL, like your HDL cholesterol. For most of the Indians, HDL cholesterol is at a lower level. In the same way, adiponectin levels are also at a lower level. So the adiponectin levels, good adiponectin levels, very good as far as your diabetes control is concerned. Very good as far as your vascular health is concerned. But unfortunately, Indians, adiponectin levels are at a lower level. So more incidence of the diabetes, more incidence of the vascular events. So how to improve the adiponectin levels? By physical activity. So the physical activity alone will improve your adiponectin levels. Again, the physical activity alone will improve your HDL levels. So the physical activity will improve the HDL, will improve the adiponectin levels. And other adipocytokines are all dangerous to the body, like your leptins, tumor necrosis factor, interleukin 1, interleukin 6, interleukin 12. So these are all the different adipocytokines which are not helpful to the vessels. On the other hand, they are very, very harmful to the vessels because they are all inflammatory mediators. So what will happen to your cytochrome storm? So there will be more and more your interleukins and they damage the vascular epitheliums and then they promote the thrombosis, they promote the plaque formations. That what happened in our COVID era. So cytochrome storm. So there's the same thing happens in your visceral fat also. So the visceral fat contains more and more free fatty acids, more and more adipocytokines, which are not useful adipocytokines, but useful adipocytokine level is at a lower level. So that is how this fat will cause diabetes in two ways. One is insulin resistance. The second one is beta cell dysfunction. So the beta cell dysfunction, lipotoxicity, etc. So the islets, your beta cells are filled with the lipids. So they don't produce more and more insulin. So that causes diabetes. And then insulin resistance because of this fat, increased fat. Again, it causes diabetes. So diabetes is a result of both insulin resistance as well as insulin deficiency. So both will be seen in the presence of your fat or obesity. So effect of the anti-diabetic agents on the weight. So weight loss. So which drugs are weight loss? Not the metformin is not the first one here. Metformin is the third one. First one is the GLP-1 receptor agonist. Okay, like oral semaglutide is available, or your dulaglutide, liraglutide, exenatide. So these are the parenteral GLP-1 receptor agonists. They are weight loss agents. SGLT2 inhibitors, like your dapagliflozin, empagliflozin. So they are the weight loss. And metformin. In some individuals, it's a weight loss. In some individuals, with weight neutral. But never it increases the body weight. So it's a very good molecule, metformin. We're very happy that most of our Indians, they need the metformin to tackle your insulin resistance. So here for the weight loss, number one is the GLP-1 receptor agonist. Number two is SGLT2 inhibitors. Number three is the metformin. Then last one, weight gain. So this is the very important. Now the people are more and more body weight. So you should not use these three drugs in type 2 diabetes. One is sulfonylureas. So sulfonylureas are weight gain drugs because the action of the sulfonylureas is they stimulate the insulin to release more and more insulin. They stimulate the beta cells to release more and more insulin. So insulin is an anabolic hormone. So the more the insulin, more the appetite, and definitely they gain more weight. And then thiazolidinediones. So this is your pioglitazone. So you have the rosiglitazone and pioglitazone. Rosiglitazone was banned. Now the pio is available. And sometimes pio also banned for some time because of the carcinoma urinary bladder. Now that controversy is over. Now again the pioglitazone is in the market. So this also increases the body weight. And of course, the insulin is a very good molecule to be used in the diabetics, and it increases the body weight. So unless the patient needs it, so don't prescribe the insulin. And even you want to use the insulin, don't use your regular insulins or your INH insulins, which causes the weight gain. So not to gain the weight gain, so insulins of your glargine or your Tresiba or your Lantus. So these are the important analog insulins. So they may not increase the body weight when compared to your regular insulins. So this is the here. So the weight gain, number one, sulfonylureas. Number two, insulin, because we use a lot of insulin and we use very rarely pioglitazone nowadays. So that is our thiazolidinediones is the third one here. So these are the good molecules which increases the weight gain. Now the weight neutral. So weight neutral is the repaglutide and atiglunide. Repa is available in the market. It's the shortest acting sulfonylurea to reduce the postprandial hyperglycemia like your Oglibos. Sorry. And the second one is the acarbose or miglitol and Oglibos, alpha glucosidase inhibitors. They are carbohydrate absorption inhibitors. So they inhibit the carbohydrate absorption. And DP4 inhibitors, your sitagliptin, saxagliptin, linagliptin, tenilgliptin. So these are all the gliptins. So for a weight individual, for overweight or obese individuals, what drugs you prescribe? You prescribe from the first and second. So the weight loss, your GLP-1 receptor agonist, if the patient can afford, or SGLT inhibitors plus metformin. Now you have the dapagliflozin plus metformin combinations. And the weight neutral, still the blood sugar is not under control in an obese individual with the first three drugs. Then you can add the fourth drug from the central group, like your Oglibos before the lunch or before the dinner, or your repaglinide before the lunch or before the dinner, before the breakfast, or the DV4 inhibitors. Now the DV4 inhibitor, SGLT inhibitor, metformin combination is available. Sita, DAPA and metformin, or Vilda, DAPA and metformin, or Lena, DAPA and metformin. So that is a good combination to use in overweight or the obese individual because it won't increase the body weight. So weight gain, these three are very important, especially the obese individuals. Please don't use sulfonylureas and thiazolidinediones. Even if the sugars are not controlled in the obese individuals, you can use the basal insulin like Lantus or the glargine and the Tresiba in those individuals, which will not increase the body weight. Health penalties of the obesity. See why we are worried about the obesity? Because increases the risk of the type 2 diabetes. You all know that. Hypertension, dyslipidemia, cholelithiasis, that is your gallstones, certain types of the cancers, especially the gastrointestinal cancers. So carcinoma esophagus, carcinoma stomach, carcinoma colon. So these are very common in obese individuals. And obese individual cancer, hepatocellular carcinoma, pancreatic carcinoma. So these are also very common. Fatty liver is very common in obese. GERD, PCOD in females, degenerative arthropathy, that is your osteoarthritis, obstructive sleep apnea, that is your snoring, etc. So these are very, very common in obese individuals. So the being overweight or obese at age 40 reduces the life expectancy by 3 to 6 years. This is very, very common. So the obesity plus diabetes plus hypertension, some people will have all these things. Most of my patients will have the 6 or 7 of these complications. Obesity, diabetes, hypertension, dyslipidemia, gallstones, fatty liver, GERD, osteoarthritis, and obstructive sleep apnea are very, very common in most of my obese diabetic individuals. So here what is the answer for all these things? Weight loss. Weight loss is the answer for them. So weight loss by non-pharmacological mechanisms, like your dietary approach. Avoid the rice. Definitely you are going to lose about 5 to 10 kgs. Only with the avoidance of the rice. So you can use the quinoa, or you can change over to the brown rice, etc. And then limit the oil. Okay. So then the exercise, at least 2 hours a day exercise. Morning walk about 45 minutes to 1 hour, and then the aerobics for about 30 to 40 minutes, some yoga for about 30 to 40 minutes, some meditation maybe the 5 to 10 minutes. If they spend about 2 hours on these things and avoidance of the rice, so no bariatric surgery. They are going to lose at least 20 kgs or 30 kgs in the next 1 year or 2 years. That is guaranteed. But unfortunately, most of our people, they don't listen our words. Okay. So then they are subjected for the surgery, bariatric surgeries. Management strategies, lifestyle modification, anti-obesity medication, very few anti-obesity medications and orlistat is available, but it is not palatable because fecal incontinence will be there with the orlistat, oily stools. Surgical treatment, as you all know, that the bariatric surgeries. Initial target, a loss of 10% of the present weight. Even as little as 5 to 10% of the weight loss can reduce the risk of the CVD and the stroke. Okay, see the benefits. Just 5 to 10% of the weight loss can reduce the risk of the CVD and the stroke. So good quality of the life will be guaranteed with the weight loss in all obese individuals. See, this is a simple picture. Body weight depends on the balance between the diet and the exercise. So more exercise and less calories. So obviously the balance will be there and they are going to lose the weight. So this is a very, very important picture. It should be incorporated in their frontal lobe. So one index case, a female 48-year-old, type 2 diabetes for the last 6 years. She is not having any micro or macrovascular complications. Blood glucose is under control. So 48-year-old female, diabetes of 6 years, no complications, good control of the blood sugars. Height 160 centimeters, weight 75 kgs. She wants to reduce her weight. What is her ideal body weight? So 160 minus 100, 60. Maybe 60 plus 2 or 3 kgs. Maybe 63, 65. Okay, even 65 is also okay. So just 10% of the weight. So about 75 kgs, 7.7 kgs. Even the 10 kgs. So that is sufficient for her. So what type of the physical activity will you advise? So that should be palatable to the patient, applicable to the patient, not 1 day, 2 days, every day. Okay. So what are the precautions one should take before advising the vigorous exercise? So as age is 48 years, already diabetic of 2 years, asymptomatic ischemic heart disease is very common in our society. So if you want to advise the aerobic exercises or vigorous, joining in our fitness center, so definitely TMT must be done before advising advising her to join in our fitness center. So otherwise, no. So while doing the heavy exercises in the gym, so definitely there may be a possibility of acquiring or getting an ischemic heart disease or sudden myocardial infarction or maybe sudden cardiac death is also possible there. So anyone aged more than the 40 years or even the 35 years, if they are the obese, so better to get the TMT before starting the vigorous exercise. So here the physical activity is important. So dietary approach is important. So all the water, all the things you know that saturated fats, unsaturated fats, complex carbohydrates, simple carbohydrates, proteins, fat, salt, fiber, okay, fruits, milk, eggs. So these are all very, very important. These are all part and parcel of our diet every day. So you have to talk on all these food items in here, and then some amount of the exercise, some amount of the meditation, some amount of the yoga. So they're all beneficial for this patient, because luckily she is interested to lose the weight. See, unfortunately, most of our people, even though they are 100 kgs, they are not interested to lose the weight. Here at the age of 75 kgs, she is interested to lose the weight. She wants to reduce her weight. So a lot to be done to her with your physical, with your approach on the diet and with your approach on the exercise. So you please spend some time with her to talk about all the ingredients of your food and also all the aspects of your exercise program. And then if she is very much interested to join in the fitness center to do some exercises, aerobic exercises, etc. So please advise her to go for the TMT first. And if the TMT is negative, happily she can practice all these things. So this is very, very important. So weight loss diets, low calorie diets, high in carbohydrate, high fiber, low glycemic index, low in the fat, reduced calories, can reduce the weight by 8% in 3 to 12 months, needs to be combined with exercise for the full benefit. All the low calorie diets, they want to reduce the body weight, needs to be combined with the exercises for full benefit. Low carbohydrate diets, high on the fat and protein, carbohydrate restricted to the 3 to 10% of the daily energy intake, not recommended since it is low in the fiber, minerals and the micronutrients. Very low calorie diets, less than 800 calories per day, consist of commercial preparations or specific foods of high biological value. Intensive monitoring is needed. Your milkshakes, your protein shakes, etc. Only indicated for the severely obese patients with compelling medical indications to lose weight rapidly. See, weight more than the 200 kgs, 250 kgs. So in such individuals, very, very low calorie, just 800 calories per day is advised for her. Not useful in weight maintenance since it cannot be continued beyond the 16 weeks. Side effects, cholelithiasis, loss of lean mass, ketosis, that is your fasting ketosis, hyperuricemia, these are very common. Very low carbohydrates, high in fat and the protein. Exercise is very, very important. See, we should start cultivating the exercise at this age group. See the child. So along with her father, doing some exercise. It's difficult to achieve the weight loss with exercise alone. Exercise can increase the effectiveness of all weight loss dietary regimens. Exercise is more important in maintenance of the weight loss rather than initial achievement of the weight loss. Exercise has other beneficial effects and should be recommended for all patients with diabetes. So what are all the benefits of the exercise? Exercise reduces the blood sugar. Exercise reduces the blood pressure. Exercise reduces your lipids. Exercise reduces your weight. Exercise gives you a good body shape, and then it gives you a confidence. So they are all very important in exercise. That also gives you cardiac health, exercise. And exercise improves your bony health, especially post-menopausal women. If they go on the exercise for about 45 minutes or 1 hour a day, so their bony health will be good. And hypocalcemia, osteoporosis, so can arrest them with a good exercise program. So exercise will reduce the sugars, BP, lipids, weight, good cardiac health, good body health, good sleep, good digestion, and no constipation in those people who are on regular exercise, and then good body shape. So they are all very important with the advantage of your exercise. Here the only available anti-obesity medication, already told you, is the orlistat. It inhibits the pancreatic lipase and reduces fat absorption. So dose about 60 to 120 milligrams. So with each meal, so sometimes you start with the lunch and you can go with the BD or with the TAD. But side effects is oily spotting, fecal incontinence and flatulence. So that is the reason it's not palatable. It's not acceptable. Weight loss 3% beyond the placebo. Orlistat only works if there is at least 30 grams of the fat in the daily diet. Other anti-obesity agents like sibutramine, rimonabant, and locarcerin have been banned in India due to the unacceptable side effect profile. So all these drugs were available 5 years ago or 10 years ago, but they didn't stay in the market for more than the few months because of the side effect profile. So surgical management is a bariatric surgery or the metabolic surgery. Procedures that reduce the calorie intake by modifying the anatomy of the gastrointestinal tract. Restrictive procedures and malabsorptive procedures. Restrictive procedures means they limit the intake by creating a small gastric reservoir with a narrow outlet to delay the emptying. So they cut the stomach, a small stomach. Gastric stapling, adjustable gastric banding, or a sleeve gastrectomy. Okay, so that can be done by with your gastroenterologist, medical gastroenterologist, or surgical. Surgical is a gastrectomy. It's a medical. They put one stapling there, some banding there. So after they achieve the ideal body weight, then you can remove that band or the stapling. Malabsorptive procedures bypass portion of the small intestine where the nutrient absorption occurs. They are the Rolexian bypass surgeries. In general, malabsorptive procedures bring about greater weight reduction and improvement in the glycemic control than the restrictive procedures. See, the malabsorptive procedures are totally a surgical procedure, bypassing. So these are the different procedures: jejunocolic bypass, biliopancreatic diversion, vertical banded gastroplasty, Rolexian Y gastric bypass. These are the indications. Benefits: weight loss, remission of the type 2 diabetes in 76% of the cases, almost a surgical cure of the diabetes. So that is the reason it is called as a metabolic surgery, because there is a reversal of these metabolic conditions. Improvement of the dyslipidemia, improvement in the BP, regression of the sleep apnea, improvement in the quality of the life, overall reduction in the mortality. What are all the benefits you can see with 10% or 20% of your weight gain with your exercise and diet approach can be seen with the bariatric surgery. The problems are there with the bariatric surgery. Okay, morbidity and the mortality are the major surgery. So some of our top people, so they following the bariatric surgery, like your Dasa Narayan Rao or some Aarti Agarwal. So some fellows know, so they died after these bariatric surgeries because of these side effects. Dumping syndrome, anastomotic leak, bowel obstruction, malabsorption of the vitamins, iron, calcium, and other nutrients. They should be on iron therapy. They should be given the calcium, vitamins, etc. And risk of gallbladder stones. Some of the weight lost initially may be regained. So some people know even after the bariatric surgery, so they regain the weight. So thank you very much for your patient hearing. And if you have any queries, I will be very happy to answer them. Thank you one and all.